Yeah, basically I was born and raised in Gary, Indiana, and actually in the 50s and 60s, Gary was a pretty nice town really. U.S. Steel was huge employment, and so the economy was good. A lot of immigrants, Greeks, Italians, Polacks, so a big mix of immigrants. Actually, my dad did the old Ellis Island routine himself.
Really?
When he was like 12 years old, his parents saved up enough money to put him on a ship to go from Athens to Marseille, France, Marseille to New York City, went through Ellis Island. He had notes pinned to his back. One was put this boy on a train to Chicago, and the next note was put him on a train to Rockford, Illinois, where relatives took him in, and kind of grew up there and worked in restaurants, and ultimately owned 2 restaurants in Gary. That's why I grew up in Gary and met my mother in Gary. So I had two brothers, one older, one younger. My 2 male cousins were more like brothers because we all grew up in the same house together, because their father died when they were real young, so my mother kind of moved in and helped raise them while my aunt went to work. So yeah, it was almost like 4 brothers. And did the usual things in the 50s and 60s. We were always playing outside, baseball, wiffle ball, basketball in the winter, just shovel the snow off the neighbor's driveway. Went to the same high school from kindergarten through senior year, Horseman High School. Gary actually had a very good public school system, probably because of the steel works. They put a lot of money into the schools. And then at that point, then went to IU undergrad in Bloomington, and I was really never sure what I wanted to do. I was always good at math. I thought maybe I'd be an accountant, but my dad kind of convinced me to go into medicine, so I signed up for pre-med. My parents owned 2 restaurants in Gary, so we spent a lot of time at the restaurants, helping out, clearing tables, running the cash register. I could run the cash register, and back then you did it all manually. There was no automatic, how much change are you do? And I could do that when I was 8 or 9 years old. And so it's an interesting upbringing. Gary also was nice because it was real close to Lake Michigan. Like we had a summer cottage on what's called Miller Beach, and so we'd spend all summer on the lake. So it was a great upbringing. And then when I went to med school, I didn't really know what I wanted to do initially. Probably when I was a sophomore medical student is when you start getting introduced to the hospital. First year and a half are just all, classes. And my physical diagnosis instructor was Dr. Richard Childress, who was perfect. He was tall, thin, kind of looked like Ichabod Crane, but unlike most university professors, he was real mild-mannered and gentle, whereas the usual professors were kind of gruff and, threw medical students under the bus. And he was a cardiologist, and so that's kind of when I developed my interest in cardiology. So I took a lot of cardiology as a junior and senior medical student, and then went to Indiana University in Indianapolis Medical Center for all my training, internship, residency, chief resident at University Hospital, 2 years of cardiology fellowship. That's all we required back then, was 2 years, because there was no special training for EP or coronary intervention. I spent 4 months of my training at a heart institute in Amsterdam, the Netherlands. So that was a wonderful experience, because we were married but no kids yet, so enjoyed Amsterdam for 4 months. And then actually, when it started time to looking for where to practice, I kind of wanted to join a small group. I could have stayed at some of the big groups in Indianapolis or at the Med Center, but really didn't want to be, the 25th guy in a large group. So our professors at IU kept telling us, some of you guys need to go to Fort Wayne, because up until like 1977, there were no cardiologists in Fort Wayne, even though they were doing bypass surgery. The radiologist would do the coronary arteriogram. The cardiac surgeon, Herendeen at Parkview and Tomas at Lutheran, would look at the films and decide if the patient needed surgery and do that. But then Parkview wanted to recruit cardiologists, and they talked the Fort Wayne Radiology into giving up doing coronary arteriograms to help entice cardiologists to come. So Bob King, who's about 4 years older than me, trained at IU, came up in '77. Bob Swint at Lutheran came up in '77, then I joined Bob King in July of '78, so I was the 3rd cardiologist in town at the time. And And yeah, it just kind of took off from there. We were not very busy initially, but it gradually grew and grew. I always tell people some of my biggest referral patterns were from coronary care nurses. Patients would come in a hospital and just be taken care of by the family doctor or maybe one of the internists, and the nurses would frequently tell the family, you ought to have a cardiologist see your husband or whatever. So that's how we started getting more busy, more popular. And then things just grew rapidly. We knew quickly, actually Bob King and I decided to recruit somebody, and in 1980, which was 2 years after I came, Bob Godley I knew real well from IU. He was chief resident at University Hospital the year behind me, and so I met him down in Indianapolis one time and talked him into coming to join us, and he came in 80, and he brought a lot of expertise in echocardiography because Harvey Feigenbaum was the father of echocardiography and was at IU, so Bob knew echoes cold. And then Mike Miro was the same year as Bob, and Mike knew Bob and I both, and he was at Iowa, on the staff at Iowa doing electrophysiology, so we enticed him to come. I believe he came in 81, a year after Bob. So we had EP in our practice at the time, which was a little unusual. I don't think either of the big groups in Indianapolis had electrophysiologists yet. You had to go to the med center. And then kind of kept growing from there. We just kept getting busier and busier and needed to add more and more guys to keep up with the pace. We usually leaned on our connections at IU at the med center, like who's finishing up, are they interested in coming up to Fort Wayne? So Charlie Presti, Steve Brown, Ray Dussman, all those guys kind of came, and they would usually know guys a year or two younger than them that were looking to go into practice. So that's how we kind of built the size of the group. I tell people the first guy that joined us that none of us knew firsthand was Dr. Pat Daly. Pat was in training at the Medical College of Wisconsin, and his program director was a good friend of ours from IU, a cardiologist, Sam Wan. And so Sam called us and said, you guys ought to interview this Pat Daly. His wife's from Fort Wayne, and they're looking around. So Pat came and interviewed, and we were all impressed. And as soon as he told me he was a fellow White Sox fan also, that clinched the deal. He was an automatic part of the group, so I had somebody to talk White Sox baseball with. So yeah, things grew rapidly. They really started growing. Back in '78, I would say most of the people coming into the hospital from the surrounding areas always went to Lutheran. Lutheran had a large number of specialists, subspecialists. They had the Dumoulin Clinic that had pulmonologists, nephrologists, endocrinologists, all the subspecialties. And actually, I knew a lot of the guys because they were a year or two ahead of me. In Park, you had several internists, but very few subspecialists. So we started going out to some of the local communities, giving talks, meeting the doctors out there. And maybe several years later, we even started having golf outings where we had kind of an educational meeting followed by golf and then dinner. So really got to know the referring doctors quite well and frequently gave talks out there, and they gradually started sending people to Parkview rather than Lutheran. And so I think that's made a big difference, not only to us, but also to Parkview. I think Parkview is far more outside referrals than Lutheran or St. Joe currently. So yeah, things just kept getting busier and busier. Our, hours were pretty hectic the first few years. Say we commonly would start at 6:30, not get home till 8 or 9. Give a lot of credit to our wives. They kind of felt like they were single parents raising all our kids because we weren't getting home very much. Back then we took night call just a night at a time. We didn't take it a week at a time like we do now. Now, as you know, we take a week of night call and you're off all day to rest up. Well, back then we'd be on night call one night and work the entire next day. And the days were real hectic. I mean, there was no sitting down for lunch or anything. Yeah, long hours, but it was fun. It was exciting. And, kind of took away some family time, but our wives were great. Back then, we used to see return patients in the office at 10-minute intervals. Now they're 15-minute intervals, but you had to be scurrying. I know there was rarely not enough time to do your chart after an patient visit because you didn't want patients to keep waiting so long. So
Stacks of paper.
yeah, at the end of the day, 4:30 or 5, you'd have 20 charts to go through. Cardiology's changed dramatically over the years, probably would think more than any other subspecialty. In '78, we took care of hypertension, medical management of coronary disease, heart rhythm disturbances with the few fairly worthless drugs that were available at the time, quinidine, Norpace, Prenestal, things that probably wouldn't even get approved if they applied to the FDA now. Took care of heart failure, mostly with diuretics and digitalis. I think the first beta blocker was propranolol, which was Inderol. There weren't really any good medicines for cholesterol. Blood pressure medicines were few. Aldomet was one of the most common ones, but you had to take that 4 times a day. Pretty hard for people to take something 4 times a day reliably. So blood pressure wasn't very well controlled. The only anticoagulant back then was warfarin. Treatment of acute MIs was basically you would put the patient on IV heparin, aspirin, maybe lidocaine to prevent VF, and then just watch them have a heart attack and try to start treating the complications that would ensue related to that. There really wasn't anything else to do at the time. Probably the biggest advancement in the early years was the first balloon angioplasty was done in 1979 in Switzerland, and then gradually in the United States people started doing it. I did my first one in 1981. Obviously we had no training for that in our training at IU because it wasn't even around then. So basically I went up to Milwaukee, Wisconsin, spent a couple days with a cardiologist there that had been doing some for about a year, and kind of watched him do a bunch, and then came back and did one. I remember my first patient that I did was an executive, CEO of a big company in Warsaw. Tom Keel was an internist in Warsaw, and he referred him to me, and I kind of kept telling Mr. Ellison, I think you probably ought to go to some major medical center where they've been doing this for a while. You're my first patient, if I were you, I'd consider going somewhere else. He goes, no, Dr. Keel recommended you, and I'm comfortable with you. So did his balloon angioplasty, and it worked well. And when I went up to his room later and then check on him, he had a bottle of champagne for me to celebrate with he and his family. So I remember that like it was yesterday. But and then back then, when people had heart attacks, we wouldn't consider doing a heart cath for probably a week or two. It would have been malpractice to do a heart cath within the first day or two of an MI. So you just, gave them heparin, aspirin, maybe a beta blocker if they didn't have severe LV dysfunction, and just wait for complications. So then we'd start doing caths and decide if the patient should continue medical management or have bypass surgery. I think it was probably later, maybe mid-'80s or late '80s that intravenous streptokinase and then TPA came out to try to dissolve the blood clot. And then some groups, especially the group in St. Vincent, started being real aggressive and taking acute MIs right to the cath lab to do an emergency balloon angioplasty. And that seemed to work real well and was safer than TPA because less stroke risk. And several years later we started doing that ourselves, taking people to the cath lab emergently. And now, as you know, that's the standard of care, acute MI. Get to the hospital quickly, open up the artery, and so that's been a huge advantage to the patients. MIs are much smaller, less complications, less death. Ventricular septal rupture is a complication of an acute MI. It's not very frequent, but I'd say we used to see acute VSDs post-infarction at least once a month. I haven't seen one of those for probably 20 years. So it's been kind of dramatic.
What was the length of stay for somebody that had an MI in the late 70s?
That's a good question. Length of stay is dramatically better for everything in medicine, but in cardiology, acute MIs would be in the hospital 7 to 14 days, that range. To show even more extreme how length of stays have changed, back then when you were going to admit somebody for cardiac catheterization for evaluation of chest pain or an abnormal treadmill, they would come into the hospital the night before the procedure, and we'd come in and see them that night, see if they had any questions. They'd get the cath the next morning. Even if the cath was normal, they wouldn't go home till the next day. So it was almost a 3-day hospital stay for a routine cardiac cath. And that went on for quite a while before it started shortening it up, come in the same day, maybe go home the same day.
After bypass surgery, they stayed a long time.
Yeah, bypass surgeries would stay much longer. So yeah, that was dramatic change. But I think the routine cath 3-day hospital stay
Yeah.
is crazy when you look back on it.
Yeah, I know.
And activity levels are dramatically better post-infarction and post-CHF, get people up and around, back into rehab. Rehab's been great for patients with cardiac events.
We would have never got somebody up right away after.
No, I mean,
Yeah.
even in like the 60s and 70s, people were like totally bedfast. They wouldn't even let them out of bed after an MI. Probably as far as the drug development's been dramatic. Antihypertensives are much better. All the ACE inhibitors, the ARBs, the beta blockers improved. They were more available. To me, one of the biggest advantages in medical drug advancement was Coreg, which is now generic carvedilol. We never would see people with cardiomyopathies recover LV function unless they had bypass surgery. It was ischemia related. But if somebody came in with a new cardiomyopathy, they were basically stuck with it. But then when carvedilol, we noticed, wow, these people are getting better. LV function's improvement. Didn't used to see that with other beta blockers.
Right.
So to me, that's been one of the most amazing drugs that was developed during my lifetime. And obviously, also is great for blood pressure. The statin drugs weren't around. That's a huge development. Dramatic lowering of cholesterol. Basically, there was nothing available back then. I mean, you could try cholestyramine powder, which was called equestrian, but
Right.
you had to take 2 huge scoops 4 times a day. It was marginally effective and huge side effects. Niacin was tried. It would actually help lower cholesterol and LDL and raise HDL, but it had just huge amount of side effects, and ultimately was found to be not effective anyway.
I recall back in the early days with heart failure, you would never put somebody on Inderal at that time. We thought
That's
that was
good.
going to be harmful.
Right. That's one of the other things I was going to bring up. I'm glad you reminded me. But yeah, beta blockers totally contraindicated for not just CHF, but if you had severe LV dysfunction, you'd have been accused of malpractice.
Right.
Put somebody on a beta blocker. Now it's the standard of care.
Yeah.
Vasodilator therapies for CHF developed in that time
Aspirin.
frame. Drugs like lisinopril for afterload reduction, IV nitroprusside. Was basically an antihypertensive.
Right.
I remember one of the first times that a patient with pulmonary edema, and I ordered IV nitroprusside for preload and afterload reduction, and his systolic blood pressure was only about 100, and the ICU nurse wouldn't start it. She called me and said, well, this is crazy, he's going to go into shock. And I said, no, it's, believe me, trust me, if you start slow and work up, he'll tolerate it well. As the improvement in his ventricular function related to afterload reduction will outweigh the drop in blood pressure effects.
And we only had one antiplatelet back then, and I'm not
Yeah,
even sure we used aspirin that much in the early
Right,
years.
yeah, Plavix obviously wasn't around.
Yeah.
We were just stuck with warfarin. There was no Eliquis, Xarelto, or
Right.
Pradaxa. So yeah, drug development has been huge.
Amazing.
And I think that's probably the next, as far as the future, one of your questions was, what do you think the future is going to bring? Hopefully, I think there'll be more genetic figuring out of which medicines are likely to work for certain patients, cardiac problems, and which ones are likely to cause side effects.
Right.
Because right now, as you know, it's all trial and error. If somebody has hypertension, you try something, if it works, great. If not, you try something else. If they have side effects, you switch to something else. And it can be a long, drawn-out process where if you knew in advance what's likely to work, that would make life much better.
Cardiology, outside of this Allen County, how did you come to expand the footprint that you did throughout Northeast Indiana and Northwest Ohio?
Yeah, probably because the outlying clinics, like I say, we started going to some of the outlying clinics, giving talks at the monthly medical society meetings, getting to meet the family doctors,
Right.
because because almost all those surrounding areas, Auburn, Whitley County, were all run by family practice, or very few internists even hit all those communities. So just got to know them, and then they started asking us to come set up a clinic. I think the first clinic we went to was Auburn, and actually Dr. Steve Cole, who was a family doctor, was the one that called me and said, would you guys think about coming up here once a week and having a clinic? So yeah, I said sure. Interestingly, Steve Cole started his family practice residency in Fort Wayne the same day I started practice at Fort Wayne, and he was on my service.
Wow.
So he was assigned to me, so we were kind of stumbling around the hospital together trying to figure out where things were. But yes, he was a great family doctor, but he invited us to come to the clinic, and then Dr. Robert LaSalle in Wabash asked us to come to Wabash, and then gradually just started going to more and more clinics, and you probably know the numbers better than I do, but I think we go to about 10 or 12 outlying clinics, and so all those patients started to change the referral pattern, coming more to Parkview and less to Lutheran and St. Joe. And initially, when I joined Bob King, we just stayed at Parkview. And then I think maybe a year or two later, Dr. Bill Clark, who I always thought was one of the greatest internists in town, who was a Lutheran, called me one day and asked if we would be willing to come over and do consults over a Lutheran. So talked it over and said, yeah, sure, why not? So started going to Lutheran occasionally and St. Joe occasionally. And that kind of expanded our time commitment and hours.
Yeah. And then when Dr. Miro came, he came more frequently.
Yeah, exactly.
Yeah.
So just each clinic resulted in more and more patients being seen and being transferred in.
So what's one of the most, or some of the most rewarding aspects of your career as you look back?
Yeah, good question. A lot of different things. I think probably a lot of the relationships with partners and staff. You know, Foreign Cardiology, Parkview Heart Institute has had very little turnover over the years. You know, we've had some secretaries that have been here 30, 40 years. Nurses, Tammy Fisher was my nurse, 33 years. Sort of a lot of very little turnover. So you obviously develop relationships with those employees. Treadmill staff, Echo, Kathy McCoy's been here forever. You know, wonderful person and employee. So I'm going to miss a lot of that. That's been rewarding, seeing all the changes in medicine and being able to help patient care. And I'll miss some of the relationships with some of the patients, some of the long-standing patients. Had a patient the other day that reminded me I started seeing him when he was 12 years old.
My goodness.
I've seen him for 40 years.
Oh my gosh.
Saw him in 1979 when he was 12. Back then, we used to see pediatric patients because there were no pediatric cardiologists in town. And, you know, if they had real complex problems at a real young age, we'd send them to Riley. But he had a bicuspid aortic valve with minimal aortic stenosis. So I saw him once a year for 40 years and finally got to the point where he needed his valve replaced. So those patient relationships are rewarding. You know, like I said, a lot of the patients, 30, 40 years.
So you talked a little bit about your early years and number of hours you worked. Were there any other challenges that come to mind as far as over the years that you've been a cardiologist?
Well, I think it's one of the reasons I wanted to join being a small group was I always thought that it would function better in a fairly small group. I was fearful of, you know, we saw other large groups, whether it be orthopedics or whatever. Once people get very large, start getting dysfunctional and, you know, disagreements between the group. But I, you know, pleasantly surprised. I think our group's been incredibly harmonious over the years. Other big groups marvel at how well we've gotten along. So that's been rewarding. There's obviously been a change of leadership over the group, and that's been good, and change is always hard, but necessary.
Right.
Yeah.
So what are you going to miss most when you retire?
I guess I'll miss being a doctor.
Yeah.
Yeah. Being needed.
Yeah.
I've worked much longer than I thought I would. I would have thought, you know, back when we were in our 30s and 40s and working real long hours, we all thought we'd either be retired or dead by the time we're 60. But Godly Miro and myself still working into our 70s. So I started cutting back about a year and a half ago and thought it'd be better to cut back and see if that's tolerable or not, and I think it has. And so, yeah, I think I'll miss being a doctor.
So who are the people in your life or career that have inspired you the most?
Good question. Probably, well, my parents definitely. My dad was very hardworking, two restaurants. People used to say in the early days, "Oh, doctor, you worked so long." I always said, "Well, I worked nothing compared to what my dad worked." So he was a great inspiration. Work ethic. Wanted all his kids to go to college. That. As far as in medical school, that's Dr. Childress that I talked about. My physical diagnosis instructor and cardiologist was very instrumental. Dr. Fish, who was chairman of the cardiology department at IU, Dr. Daly was chairman of medicine and subsequent dean. Dr. Fish was the one responsible for sending me to this heart institute in Amsterdam. I remember like yesterday, my wife Sharon, when I was a resident, said, you ought to see if you can spend some of your training in England or somewhere, just, a little change of pace. I said, okay, well, talk to Dr. Daly, chairman of the medicine department, talk to him, and he goes, yeah, that's fine with me, but I really don't know anybody in Europe that well. Why don't you talk to Dr. Fish? He's more internationally known. And I had spent a month with Dr. Fish on a cardiology rotation as a senior student, so I knew him. And then went to talk to him and told him what I wanted to do, and he said, well, there's a heart institute in Amsterdam, they speak English there, so you want to go there? I go, yeah, sure, why not? Sounds good. And he goes, how long are you going to go? I said, oh, probably a couple months. He goes, oh, you got to go for at least 4. I said, okay. And he goes, is Dr. Daly going to pay you out of the medicine department? And he, yeah, well, he wasn't sure he could or not. And I said, I can get by for short term. We weren't getting paid much then anyway. He goes, well, don't tell Dr. Daly, but, if he doesn't pay you, I'll pay you out of the cardiology department. And then he said, the last thing was, he goes, do you still want to do your cardiology fellowship here when you're done with your internal medicine? I go, yeah, I'd like to. And he goes, well, you can count on it. Yeah. So I kind of floated out of the room. This supreme being had just arranged my entire career in about 15 minutes. So that's why he's high on my list of instrumental people.
So Dr. Genetos, what are your plans for retirement?
Yeah, good. I'm a golfer, and we've sold our Fort Wayne condo. We have a home on Wawasee, so we'll spend half the year there, and then the other half of the year we're going to spend. We bought a small condo in Hilton, South Carolina. I have a good friend there. Sharon has 2 of her best friends living there. Our daughter's in Atlanta, which isn't far away, so we'll travel some once the pandemic resolves. Our son is in California with 2 kids, and Nicole's in Atlanta with 2 grandkids, so we'll spend more time visiting them and golfing and reading and things like that. I've been an early riser forever, so I'm sure I still will be. It's going to be hard to get out of that habit. I'm sure there'll probably be some days I'll wake up and have done everything I wanted to do, and it's 6 o'clock in the morning, and I'll think, well, what am I going to do now? There won't be any tasks to do.
Yeah, you're not going to miss that.
Right.
Yeah.
So yeah, I think I'll stay busy.
Yeah.
And cutting back was a good idea rather than working long hours to being totally retired abruptly. I don't think would have worked well.
What would you like to tell your partners or the rest of us on your departure?
Oh, I'd say be very appreciative of what you got. Parkview's been great to us over the years. The partners have been great over the years. The staff is great. I'd say be kind to the patients and the staff. And just appreciate what you got.
You have anything else to add?
Let me see here if I had wrote a few things down.
You covered everything. I didn't have to ask a lot of questions.
Yeah, I think that's most of it really. So yeah, when I came here, you talked about how you ended up here. Well, people told me I ought to look at Fort Wayne, so I came up and interviewed with Bob King, who was about 4 years older than me, but who was from Fort Wayne and did his training at IU. And so I came back to Indianapolis and told Sharon, I'm pretty sure I want to move to Fort Wayne. And she goes, well, you must have forgotten that I told you there were 2 things I kind of wanted. One was, if we leave Indianapolis, I wanted to go somewhere warmer and somewhere bigger. You must have the map turned upside down.
2. Yeah.
Right.
Yeah.
But it worked out great,
Yeah.
And Fort Wayne's close enough to Indy; it's not a big deal.
But
I grew up in Gary, so
yeah,
it's close to our families.
Better than Gary, I guess.
Yeah.
Yeah. So, you kept your lake cottage, right?
Yeah, we kept our lake
You're gonna
home.
keep that?
Yeah, we're keeping that and divide our time between Hilton Head and
Yeah.
the lake. And actually, we sold our Fort Wayne condo in May, so I've been
Right.
commuting from the lake for
Right.
the rest of this year, which is
Right.
soon to end.
Right.
So yeah. Yeah,
Well,
it's great.
I've been part of that journey since late 1984, so I've been proud to be part of Fort Wayne Cardiology and now PPG-Cardiology. But if it were not for you, none of the rest of us would be here today.
Yeah,
So
well,
we
thank
really appreciate
I know it's been a team
your
effort.
contribution to cardiology in Fort Wayne and the surrounding areas.
Yeah, I think it's been a team effort. You know, you've been here forever.
Yeah.
You've been great.
Yep.
The nurses have been here forever. Partners have been great. There's very few people that joined the group that left. You know, maybe a couple we got rid of and a couple wanted to do something else.
Yeah,
But other than
rare.
that, there's an incredibly low turnover.
Yep.
Hospitals have been good, especially the current leadership. Mike Packnett
Right.
and his crew have been great.
Right.
So yeah, I think, you know, to the younger partners, you just appreciate what you got, because it's hard to imagine a better practice. One other thing about wives, you know, Sharon was willing to go wherever I wanted to go, which, and back then was the same, you know, the physician could help decide where he wanted to practice and the wives would follow along. Well, things have changed over the 40 years. We've had several guys that we asked to join the group. They wanted to join the group, but the wives said no. You know, they wanted to go
Right.
either Indy or Louisville, somewhere larger. And I think that's their loss. But that has changed over the years.
You don't hire just the physician, you hire the wife too.
Right.
If she doesn't want to come, it's not going to work
Yeah,
out.
right. But back then, the wives were willing to
Yeah,
follow you,
yeah.
right?
Well, thanks for your time today. I really
Oh, yeah, no,
appreciate it.
thank you. I've
And I
enjoyed it.
wish you the best in your retirement.
Thank you. Yeah.